Hello everyone, I am Sulu Fan. Today, let's learn mitral regurgitation, or MR. The causes of MR involves the valvular leaflets, enlarged valvular ring, chordae tendineae, and capillary muscle. Still, the rheumatic injuries consist of 1/3 of the cases. Because the MR can be classified into acute MR and chronic MR, the pathophysiology should be a little different. For acute MR, the left atrium and the left ventricle will increase the preload abruptly. Because there is no time to compensate for the left ventricle within the short time, the end diastolic pressure of the left ventricle and the left atrium will be elevated abruptly, then lead to the pulmonary congestion and pulmonary edema, and also the decreased cardiac output or hypotension. In the chronic MR, if it is a compensated one, the preload of the left atrium and the left ventricle will be increased but compensated by enlarging the left ventricle. However, the end diastolic pressure of the left ventricle cannot be elevated for a long time. If this state persists for a long time, it will become decompensated. The left heart failure and pulmonary hypertension, or even the right heart failure, will appear. In the acute MR, the clinical manifestations is usually severe, such as acute left heart failure, acute pulmonary edema, or even cardiogenic shock may occur. But for chronic MR, the patient may be asymptomatic for a long time. Some of them only complain fatigue or dyspnea. For acute MR, the apical beat may be forced, and there is a loud S2 sound. Sometimes we may hear the S4 sound. There will be a low-pitched decrement systolic murmur at the apex. Simultaneously, in severe MR, we can hear the S3 sound at apex and the rumbling diastolic murmur of a short duration. In chronic MR, the apical beat may be shifted downwards and leftwards. The heart sound of S1 sound is weak, with a splitting S2 sound. In the mitral prolapse, there will be a mid-systolic click sound. There is a hollow systolic murmur, which starts with S1 and continues to S2 around the apex area. This murmur may be radiated to the back or clavicular area. On the chest X-ray, the heart especially the left atrium, may be slightly enlarged in the acute MR, but with an obvious pulmonary congestion. For the chronic MR, both left atrium and left ventricle become enlarged. And we can also see the pulmonary congestion or interstitial pulmonary edema. Sometimes there will be mitral ring calcification. The clinical manifestations on ECG is usually nonspecific. Only sinus tachycardia, left atrium enlargement, left ventricle hypertrophy, nonspecific STT change, and even some arrhythmias, for example, the atrial fibrillation. Here is the echography. In this video, we can see both left atrium and left ventricle are enlarged. Usually, the left ventricle function is reduced. There is an obvious mitral regurgitation across the mitral valve. If this is associated with myocardial infarction, we can see the segmental wall motion abnormality at the same time. In addition, if this is associated with endocarditis, we may see vegetations. Regurgitant area, regurgitant volume, and regurgitant fraction can be used to grade the severity of MR. If the regurgitant fraction is above 50%, it is a severe MR. The complications associated with MR include heart failure, atrial fibrillation, infective endocarditis, and embolism. Regarding as the treatment, medications are usually the first choice. We use the vasodilator and some medicals which can reduce the heart rate. And we can also use anticoagulants in the atrial fibrillation or atrial flutter. If there is fluid overload, we may use diuretics. The surgeries associated with MR includes mitral valve repair or replacement. And also, we can use transcatheter mitral valve repair, which is relatively non-invasive. That's all for today. See you!